Okay, so hi everybody. So actually, I don't know whether we need to repeat or not some of the discussion we had over the last couple of minutes. So I don't know, Vasily, do you want to make, I mean, today we'll talk a little bit about some analysis relating cognitive status and EEG data. And it's actually, these are analyses that Vasilis Kimiskidis and Andreas Kyrozis are leading. But because they are done in this study, the ALBION study, I thought maybe I will introduce the study and then let Vasilis and Andreas give us some information. So you can see the title. If one wants to find more details about the study, we just have a single publication. We're working on many fronts, and hopefully we'll have quite a bit shortly, including the EEG data that we will share with you. So the subject recruitment happens at the Cognitive Disorders Clinic at the Unity Hospital. And it's a prospective study. It started 2018. And the aim is to investigate preclinical and prodromal stages of dementia. And this is why, actually, as you can see, let me see if I can. Okay, as you can see here, we recruit participants who are either normal or MCI, so we do not include people with dementia. And even if it's MCI, we try to be, you know, pre-MCI or early MCI. There are different definitions. So, there's a particular emphasis on lifestyle, including sleep, nutrition, and so forth. And it's a wide range of ages starting from 45. So that's the general, you know, concept. We collect a lot of medical and clinical information on these participants. We ask them about subjective cognitive complaints, their neuropsychiatric status, their lifestyle, cognitive, physical and social activities, about their everyday function. We administer various scales, including scales related to mobility, like the UPDRS for extrapyramidal signs, the Hashinsky scale, the CDR. We give them a full battery of neuropsychological testing, try to assess, as many cognitive domains and to as much detail as possible. A requisite to be part of the study is to have a lumbar puncture. So we take CSF, we assess the biomarkers of neurodegeneration, and we save specimens for future research. We draw blood and we save it. We collect stool for future microbiome analysis, and we save it. We have an MRI, a 3 Tesla machine using the European Prevention of Alzheimer's Disease Dementia Consortium protocol. We assess their sleep. We give them a sleep questionnaire, but we also give them an actigraph to wear for a week. And then we have data that we can analyze either as summary measures or in time series. We ask them about their physical activity. Actually, the slides were reversed. Regarding their sleep, we asked them also to watch this watchpad, and we have some information on different sleep stages. And we asked them about their physical activity, and we have some objective measure of motoric function. We measure their sleep, their speed, the speed of their gait. We also measure their grip strength, so we have some indications of frailty, together with the gait speed. We ask them about nutrition, of course, and while most studies use food frequency questionnaire that assesses habitual nutritional information, we actually employ 24-hour recalls. And why do we do that? Because we want to investigate the chronobiology of diet. This chrononutrition field is an emerging field looking at not only what you eat, but when you eat it, in relation to the time of day, in relation to sleep, and so forth. And finally, we do an electroencephalogram, and this is what we're going to talk about today. So this is a brief overview of the study, just 1 or 2 more slides. So to give you a sense of how it works, we get consent, we get the brain MRI, we ask them to wear the actigraphy, and we give them the watch pad, and this is for 7 days. In between, we call them to get the dietary information. They come back a week later. We have all this information that I showed you before. And then we try to have the electroencephalogram within at most a month from these assessments. So we try, it's a lot of visits, a lot of assessments, but we try to keep it as close together as possible. And then this is the first visit. On the second year, a year later, we do some cognitive scales and neuropsych testing. And then on the third visit, we try to repeat the electroencephalogram, and we try to repeat some of the biomarker collection information, but of course, not all of them. And then a fourth visit, a year later, just some brief cognitive stuff. So it's a prospective study. Hopefully, we may be able to analyze prospective data before, in the future. So I will stop here so that we can hear a little bit more from Vasilis and Andreas.
Thank you, Nick. This is obviously a very comprehensive study. I don't know if you would like to have a discussion at this stage following its presentation. What would you suggest?
I think, I don't know, maybe, I don't know how we will go in terms of the, maybe could, I guess, could Andreas maybe present, some slides on some background and some basic information on the subjects, on the participants that were included in these analyses? What do you think?
Okay.
And maybe, Vasily, you can tell us a little bit more about the analysis. And,
yes, sure.
Andrea?
Oh, okay, I can present very briefly the background and the methodology. So I will share the screen. Okay. All right, so the main EEG changes that we see in dementia and are visually evident in the routine reading of the EEG are first the reduction of the frequency of the posterior dominant rhythm, which is normally between 8 and 12 hertz, and even in old age, if there's no demanding process, it should still be above 8 hertz. Whereas if there is a demanding process like Alzheimer's disease, the frequency of the posterior dominant rhythm gradually declines. And if we see a frequency less than 8 hertz, it's considered abnormal, even in an elderly person. The problem with that is that there's a significant variability among different normal subjects. Somebody may have 8 hertz and somebody 9, 10, 11, 12. So with just one EEG, it's not at all an accurate measurement of a possible process. Another metric that we regularly use is the amplitude of the PDR, which is reduced in case of degenerative illness. Again, there is so much variability. Some people don't even have any PDR at all. So again, it's not a very useful marker of degenerative disease. Of course, it's much more clinically useful if somebody performs successive EEGs. So in that case, it has some diagnostic usefulness. So even on a purely clinical level, yes, it's good to perform EEG in somebody when degenerative disease, Alzheimer's or FTD or some other disorder is suspected. But what we would like to do is to have a useful and a reliable biomarker. First, a diagnostic biomarker and also a prognostic biomarker. Even if the diagnosis is not in doubt, we would like to have prognostic biomarkers, be it chemical, imaging, electrophysiological, or whatever. So there's clearly a need for further development of biomarkers of many types, chemical, imaging, and EEG. There have been several studies, several groups have developed computerized EEG biomarkers. However, as the case is with the visually evident markers, there's high intersubject variability in the computerized EEG markers, even in normal people. So again, there's even after so many studies, there haven't been any generally accepted and widely used EEG biomarkers for the diagnosis and follow-up of Alzheimer's disease or any other degenerative condition. Another limitation is that most EEG signal analysis studies have been done comparing AD to normal people. There are few studies on MCI. Another limitation is that most studies have been done without CSF or imaging biomarkers. There's usually a clinical diagnosis, and that's it. So there are still generally no acceptable EEG biomarkers. So what is the methodology we use? It's very simple, routine EEG with one modification. the rationale of using a long time with eyes open is to measure some biomarkers with both eyes closed and eyes open, and do some kind of ratio, because the variability in a biomarker when you have a ratio in two different states in the same subject is generally much lower than the variability of a single state biomarker in different subjects. So the rationale first developed by the group in Sheffield was that we not only obtain a long time in eyes closed, which is the routine, but we also have a long time with eyes open. So the protocol is have eyes closed for 30 seconds, then open eyes, have them open again 30 seconds, which is not routinely done in other EEGs, but this is the difference with the protocol. Have a long open eyes time and repeat that 5 times, so that we have 5 periods of eyes open and 5 periods of eyes closed. So this protocol has the advantage of being very simple to replicate. So in principle, if we manage to find some useful biomarkers, it can be replicated in other labs. That can be a routine EEG, and just give the EEG to calculate the markers, and this should have clinical usefulness. So that was some background, and then I don't know if it's good time to give to Vasilis what is the next step in one set of analysis. Of course, there can be several types of analysis, but Vasilis and his team have developed a very complex, sophisticated, and powerful set of analysis for the EEG of this protocol.
Andrea, sorry to interrupt. Do you want to give I don't know whether you have any slide with some basic demographics, or do you think we should show it now before, or Vasilis should, to give a sense to people on how many subjects, or you think it's better to talk about this later?
Okay, very simple. We have so far analyzed 86 subjects, either normal or with MCI, and the analysis of the results, the results shown by Vasilis are based on 86 subjects. So that's very simple. There's not much complexity to it.
Okay, I think this was an excellent introduction to my subject. Thank you, Andreas. Obviously, we'll come back to this point because we need to discuss the future directions that this project will have, and so immediately after my talk, I think we need to discuss along these lines. So, if I can share my presentation as well. So this is, let's say, the revised program of our session today. And what I will do is that I will focus a little bit on the challenges that everyone who wishes to perform EEG in the field of dementia faces nowadays. I will show some preliminary results on this project that, let's say, had the ambition to address some of these challenges, and we'll discuss, all of us, at the end about the future prospects. So I also want to note that these analyses that I will present were made in collaboration and actually primarily by two colleagues of mine, two mathematicians, which hopefully are present in this session as well, Professor Kyrozis and Professor Vlachos. So if there are any questions of a technical nature about how these methodological problems can be solved, they are here, and I'm sure they will be happy to address and answer. So let me start with some very general comments. You all know very well that making an accurate and timely diagnosis of Alzheimer's disease is a challenging task. And you very well know that the cornerstone is clinical. It is the performance of some neurological and neuropsychological tests that measure quantitatively several aspects of cognition. And of course, these clinical tests are applied in conjunction with some neuroimaging and cerebrospinal fluid biomarkers that support, on one hand, the diagnosis of Alzheimer's disease and exclude all other alternative diagnoses. This is very straightforward, very basic, but in practice, there are certain drawbacks. Now, the first drawback is that the performance of these clinical tests, either neurological or neuropsychological, requires expertise, requires experienced clinicians and psychologists, and of course, requires lengthy sessions as well. And both of these render these sessions, these first diagnostic process subjective, operator dependent, and of course, time consuming. Now, the second issue about the CSF biomarkers, of course, they disclosed a lot about the neurodegenerative aspects of the disease, but they require a lumbar puncture, which is invasive and therefore not easily applicable in everyday clinical practice, at least in every setting. And third, the neuroimaging tools, and particularly the sophisticated neuroimaging tools, for instance, the PET scanners, may not be widely available, for instance, in low-income countries or even in the periphery of a country. And in any case, they are certainly costly. Now, for all these reasons, for these three reasons, it would be highly desirable to be able to use an accurate and non-invasive and widely available biomarker for diagnostic and prognostic purposes in Alzheimer's disease. And this is where EEG comes in. We all agree that the progress in the investigation of the human brain in health and disease, which was brought about by neuroimaging, is huge and is constantly increasing. And yet, electrophysiological techniques like EEG are still in the 21st century highly relevant, both for clinical and research purposes. And the reason why, for the younger members of the audience, is nicely depicted in this graph. So on the x-axis, we have the spatial resolution of these methods. On the y-axis, the temporal resolution of the electrophysiological in the dotted circle versus the imaging in the solid circle techniques. And it is clear that EEG, in contrast to functional imaging techniques, for instance, fMRI, is characterized by extremely fine time resolution in the millisecond scale. Now, why this is important? It is important because it captures cognitive processes in the time frame, in the real time frame that cognition operates. The brain functions in the millisecond scale, not on the second scale. A second issue, a second advantage, if you like, is that EEG directly measures neural activity, unlike, for instance, fMRI, which, as you very well know, discloses the hemodynamic correlates of neural activation. Third, EEG is inexpensive. It is lightweight, it is portable, and of course, it is widely available all over the world. And finally, which is of particular importance to me, EEG can be readily combined with brain stimulation techniques, for instance, transcranial magnetic stimulation, which allows the development of active rather than passive recording paradigms. And we strongly believe that these can disclose covert aspects of brain function. For all these reasons, EEG has become an extremely popular tool in the investigation of dementia. Currently, there are more than 2,400 papers. There were more than 216 papers last year alone. And as you see, the interest in this application is exponentially increasing. Now, a perplexing issue is that the reported results from all these studies are at times conflicting and in certain cases fantastic. Let me give you an example. This is a recent multi-center study by Vecchio and co-workers in a large sample, 295 subjects, 120 healthy volunteers, 175 with Alzheimer's disease. Now, the authors performed source analysis, so these data do not refer to the sensor level, the electrode level, but in 80, sorry, this is my dog, but in 84 regions of interest in the cortex. And the connectivity between these 84 regions of interest was estimated with a measure which is called lack linear coherence. I should also stress that EEG in this study was recorded with what we call low density. They had between 19 and 22 electrodes amongst the various laboratories that participated in this multi-center study. Now, the results were entered into a machine learning classifier, and they were very impressive. You see, 95% sensitivity, 96% specificity, and 95% accuracy. Now, this is fantastic because all this happens in a completely automated manner. But let us ask ourselves, if this indeed happens, if this indeed reflects everyday reality, why don't we diagnose Alzheimer's disease with EEG at our everyday clinical practice? I can hardly imagine any other technique that is able to provide an accuracy higher than 95%. So let us ask again, is EEG indeed so accurate? And this is the question that we try to answer from the very first moment. This is why we decided to design the present study. So the principal study objective of our study was to explore, let's say, the discriminative ability, or more formally, the diagnostic accuracy of EEG in Alzheimer's disease and MCI. Now, when we designed this study, we didn't merely want to replicate the 2,400 studies that are already there. We wanted to take into account the limitations that have been previously noted in many of these studies and have been nicely summarized in this review article by Kasani, and try to address at least some of these limitations. Now, the first limitation, as you see, is a small number of enrolled subjects in relevant studies. So what did we do? We employed two databases. The first database is the one that has been nicely presented by the two previous speakers, Professor Skarmes and Professor Kyrozis, the database at the Eton Hospital. And the second database is provided by the NK Lab, which is at the Center for Research and Technology in Thessaloniki. This is the so-called IPTIL, and you see the collaborators from this for this study in brackets in the slide. Now, the second database, as you see, comprises EEG recordings from 48 Alzheimer's disease, 79 subjects with MCI, and 69 healthy controls. A second issue, a second limitation, if you like, is whether merging databases is valid, is okay, or whether local differences between centers that participate in a multi-center study render this merging action invalid. And the simultaneous assessment of the two databases I referred to is certainly an opportunity to address this issue. A third limitation noted by Kasani and co-workers is the lack of broad inclusion criteria, meaning including patients at various stages of the demanding disorders. And this, again, can be addressed by our study since we included both healthy controls, MCI patients, and Alzheimer's disease. And a final limitation concerned the lack of age and education matching between the study groups of each study, which was also taken into account in our study. Now, this first set of limitations concern the populations enrolled. The second concerns the experimental setup, and this, of course, is of paramount importance. Now, one issue relates to the presence of dominant alpha activity during the eyes closed condition, which probably confounds the results. So how do we address this? We study both during eyes open and during eyes closed, as well as the difference, and Andreas alluded to this, and I'll come back to this later. A second pre-processing issue relates to differences in data sets as a result of manual artifact handling. Now, in order to solve this issue, we applied, my collaborators, my mathematicians applied a cascade of advanced cleaning procedures, which you can see in the slide, and which essentially nullify the manual interventions in artifact handling. So this is done all automatically. And finally, a low number of electrodes, meaning electrodes, 19 electrodes in most studies, has been reported as an obstacle in performing both source localization and connectivity analysis. And again, we were in position to address this limitation as well by including both low and high density data. Now, a very, very critical aspect of data analysis relates to feature selection and classification of the data, which is schematically demonstrated in the flow chart above on the left. This is, let's say, a rather complex procedure, and there are certain pitfalls when someone tries to perform this procedure. Now, I'm just showing you two of the most important. There are many pitfalls, potential ones. Now, the first is to perform what is called cross-validation, usually tenfold cross-validation, based on data segments rather than based on the subjects themselves. And a second wrongdoing is performing the feature ranking and selection part of the analysis on the whole data sets on all subjects. Now, we can discuss in detail what exactly these two pitfalls mean, but I just want you to see the impact of these wrong approaches if we do not account for them. Now, the diagram on the left depicts the classification accuracy for differentiating patients with Alzheimer's disease and healthy controls as a function of the numbers of features on the x-axis. Now, the two wrong approaches, which are shown in blue and red lines, artificially inflate the accuracy as more features are included. Actually, the accuracy of these two wrong, I emphasize, approaches reaches almost perfect performance, 100%, while the true accuracy is around 75%. Now, the lower right diagram shows the same for MCI patients versus healthy controls. Again, the two wrong approaches artificially inflate the accuracy. And an even more impressive pattern is what my colleague Yanis Vlachos presents here. This is, let's say, a crystal clear presentation of the impact of these wrong approaches. So he randomly split the healthy control group into 2 equal sets, and he performed the whole classification process. And you see that the wrong approaches, the blue and the red line, are able to perfectly separate the 2 groups, suggesting they are different when in fact they are not. They are both healthy controls, while only the correct approach, which is shown in black, is able to correctly not discriminate them. Okay. Another limitation that has been pointed out in the literature by Dawes most clearly, but many authors have discussed this, is that in most existing studies, a single measure to detect EEG abnormalities is applied to a single EEG dataset. And this occasionally leads to conflicting results. You see on the left in the slide a study by Farina and co-workers concluding that EEG had a sensitivity of less than 70% for differentiating MCI versus healthy controls. And you see on the right another study using a very specific measure, suggesting that the accuracy is almost 98%. So what is the truth? Now, Dawes suggested that in order to be comprehensive, we need to combine various EEG characteristics. We do not have any good reason to hypothesize that the brain functions according to a specific measure of connectivity or otherwise. So perhaps the best approach at the moment is to include all available measures. Now, he says that few studies have systematically investigated large collections of EEG features, and it would be of great interest to apply dimensionality reduction methods and investigate perhaps thousands of EEG features to discriminate, to determine the most discriminative EEG features in a disciplined way. And this is exactly what we did. This is, let's say, an approach that we have previously employed with my colleague Dimitris Kouyoumdis. Now the same approach has been applied here. So we have many measures. All in all, we had more than 4,000 features. Now the measures are divided into univariate and multivariate. The univariate are further subdivided into simple statistical measures, correlation measures, measures of dimension, entropy, and complexity, measures of frequency, content, and model-based measures. And in addition, my colleagues performed multi-channel analysis. They did this by combining 2 approaches. First, they computed a Granger causality measure for each pair of channels so that the connectivity network is formed. And then they computed various indices, other global or local indices on the derived network. Okay. Initially, we were thinking about performing this approach both at the sensor at the source level as well, but for time reasons, we were restricted to the sensor level. So I'm coming to the results with this rather strict and rather comprehensive methodology. Now, very, very synoptically, using this approach, the accuracy for differentiating healthy controls from Alzheimer's disease was 82%. And this was achieved with the metrics that are shown on the right. These are the 10 best metrics. The most discriminative one is the last, so declination from linearity, and then all the others follow. So 82%, not bad. But this drops to 60% when we investigate the diagnostic accuracy of this approach for differentiating MCI patients from healthy controls. As you see, the 10 most discriminative features are different and are located in different electrodes. Now, the differentiation of MCI from Alzheimer's disease was reached with an accuracy of 70%, again with a different set of highly discriminative features. You see, the best one was the maximum Lyapunov exponent at F3 electrode, and then followed coherence, autocorrelation, and other features. So, in our humble view, these are the best values you can get for the diagnostic accuracy of EEG in Alzheimer's disease and MCI patients using this strict methodology. Now, as you already understood, we did not merge data. And we did not merge data between the IPTIL and the ALBION study for a good reason. Because first, we asked ourselves if we can indeed combine these two data sets. So we did the same approach, try to see if we can differentiate data coming from the one or the other source. And you can see in the graph that indeed we can perfectly separate the two data sets, meaning that there is some systematic difference which relates not to the brain differences of Alzheimer's disease versus healthy controls, but to the recording conditions, the elimination of artifacts, and so forth and so on. Okay, now the results of the ALBION study have been presented and will be discussed more with Andreas. This is the eyes closed condition in age-matched and education-matched controls. You see that the accuracy is around 56%. This was statistically significant. We performed a statistical significance test, and indeed, it shows that the first 6 features were statistically different between the two groups, healthy controls versus MCI. Now, with eyes open, this increases slightly. Again, it is 0.57, which is not very different from the 0.60, which we observed in the IPTIL dataset. And finally, when we try to see the difference between the eyes closed and the eyes open condition, we did not get any significant improvement in the diagnostic accuracy. But we have to think clever, and here we merely found the median of the metric of all these metrics in the eyes closed versus the eyes open condition. We have to do something better here. And my last slide is this, and I will pass on to Andreas and Nick, because this is the correlations, the statistically significant correlations between the various aspects of cognition when they are investigated with this clever approach. They are transformed to these Z metrics, and now we do not have, we have a continuous variable, and we can make nice correlations. And you see that both in the eyes open and the eyes closed condition, several of them are statistically significant. I believe the first answer to the question we posed years ago on what is the diagnostic accuracy of the EEG can be answered as above. Now, the prognostic accuracy is another issue. We will address this because we have the data from both data sets. We will do that. But what we have to think is how to move ahead, how to improve this diagnostic accuracy. And I'm happy to discuss and hear other ideas. So any questions, any comments? And Nick and Andreas, perhaps you want to take the lead.
Yeah, thank you, Vasilis. Andreas, do you have any other slides to share?
Yes, I can share one further analysis. Okay, what Vasilis showed very nicely with some detail was basically, now what he showed in the last slides was correlations of metrics with z-scores of cognitive scale scores by cognitive domain. He showed several cognitive domains. We performed here one further analysis of the data given to us by Vasilis, the analyzed data, and we did some further analysis of the 20 selected metrics versus the cognitive status, that is normal versus MCI. So there were 10 selected metrics for the closed eyes and 10 for the open eyes. These were, as I understand, metrics that showed the best promise, the best correlation regarding the cognitive scores in the certain cognitive domains. So these 20 measures were tested versus the diagnosis, that is no cognitive impairment, or MCI. Basically, there was no dementia. Everybody was MCI, and there was some overlap with the correlation seen with the scales, but not 100%. There was actually a single metric that I'm not even sure what the physical meaning of this metric is, that in both eyes closed and in eyes open showed a very strong correlation with presence of cognitive impairment versus its absence. So this is clearly one of the of the metrics to go and study further and to explore its physical meaning. But of course, as Vasilis said, we need to concentrate on groups of metrics measures. But certainly, when we find some metrics that seem to be promising, clearly this can form the basis of further thinking and analysis. So the statistics were very simple. We did a quantile regression, and the dependent variable was each of these metrics, and with independent variables, the diagnosis, sex, age, and education. So this was a preliminary result associating the diagnosis, normal versus MCI, with the metrics. And this was a ROC curve for the two most promising metrics. This was the eyes closed, and a similar ROC curve with the eyes open. So by single metric, as you see, we don't get very high specificity and sensitivity of the test. So clearly, a combination of several metrics has to be found to achieve the best possible results. And this Vasilis already showed this table and this. So let me very briefly mention what are the immediate future directions. So as Vasilis said, even though the results were not particularly positive, one thing to try is to calculate some kind of ratio between a metric with eyes closed versus the same metric, or perhaps different metrics with eyes open for every subject. rationale being that the eyes closed to eyes open relative metrics are theoretically and I think also practically have much lower intersubject variability compared to single eye state metrics. So that's one thing. Another thing that may be related to the suboptimal ability of several studies to find good correlation is that often diagnoses are clinical, and another problem with diagnosis, a binary diagnosis, is it neglects the possibility of mixed diagnosis. So there could be Alzheimer's plus vascular disease, or some cases there might not be Alzheimer's disease, but some other degenerative condition. So clearly, the inclusion of biomarkers in the analysis will help us have more accurate results. And also another thing we plan to do is the prospective study of baseline EEG versus subsequent cognitive decline to see what, if any, markers we could find that have a prognostic value. And another aspect is prospective study of EEG changes versus cognitive decline. The first traditional example of this is the lowering of frequency of the dominant rhythm and its amplitude, but there's clearly a lot that can be gained by analyzing a full set of EEG biomarkers. So this was a very brief outline of some of the future directions.
Thank you, Andreas. I fully agree. Perhaps some people would like to comment, suggest ways to move ahead. Kostas, please.
Hi, everybody. Very, very nice work. I guess I'm thinking it might make sense to take a step back and think through the general strategy here, because I think there are a lot of themes that are interwoven that are probably best to separate. So I think the question you posed at the beginning is that there is this entity that we call dementia due to Alzheimer's disease, or MCI due to Alzheimer's disease. In other words, an etiologically based diagnosis for a clinical syndrome, and that we're trying to apply efficient, straightforward, widely applicable tests to differentiate these rather heterogeneous entities. So I think it's important when we have this kind of a challenge to go back to the ABCs of clinical epidemiology. And given that we don't expect the EEG to be a specific test, it's not measuring the specific pathology, so it's not something that we could ever expect from it. But to use a strategy that is commonly used in other areas, but not enough in neuropsychiatry, which is assigning to each additional test a likelihood ratio of the positivity or negativity of the diagnosis. I think the idea of likelihood ratio is that in any situation, you can set a prior odds of someone having the condition in question. You can do that with normal people. If you take an 85-year-old off the street, you can assign a prior odds that that person has or does not have the diagnosis in question. And then you can refine that further into a clinical environment where you've got some aspect of a clinical evaluation, and that tells you a different prior odds. So grounded in that, you then apply a series of clinical tests whose likelihood ratio is known. And there's a very simple process. You take the prior odds, you multiply it by the likelihood ratio. You can add as many tests as you want, and then you get a posterior odds. So let me illustrate that by way of example. In our hands at our memory center, if we diagnose someone with probable Alzheimer's disease after decades of follow-up autopsy studies, we know that they're going to have the brain pathology 90% of the time. So you can do a calculation, take that probability and translate it into prior odds. And so now we want to further refine the accuracy of our diagnosis. And let's say we apply an ApoE4 diagnostic test, which has a likelihood ratio on the order of 2. So an ApoE test for presence or absence doesn't really change the posterior odds very much. It's not a very influential test. If you add a PET scan and you've got a positive amyloid PET scan, then you're getting closer to a posterior probability of 90%. So I just wanted to make the point that I think in neuropsychiatry, when we are trying to improve our diagnostic acumen, we've got to be careful about what we're trying to diagnose. And unless we have specific tests, we need to be thinking of the tests in the context and examining them by evaluating their likelihood ratio as a means of deciding what the value of the test is going to be. And I think as exciting as your work is and your very careful methodologic approach, I would be curious to see what the likelihood ratio is of EEG in assigning the diagnosis, because that then allows you to compare with CSF analysis, with a single cognitive test like a MoCA, all these other tests that we might apply to the prior odds of the situation. So I thought it kind of worthwhile for us to step back and think of the bigger picture about what we're trying to do and how does EEG fit into that effort.
Thank you, Kostas. Excellent remarks. We need to take into account these remarks and indeed go back to our data because, as we said in the beginning, this is work in progress, so we can surely address this these comments. Thank you. Yanis?
Yes, thank you also for this fascinating presentation. So it raises a lot of questions that I think are relevant to clinical practice, but I was trying to imagine, or let's say to picture how this will be introduced into the clinical practice, if ever. Like, we do some neuropsychological tests, we do some imaging studies. We have a usual routine practice to diagnose the patients. So which patients do you think could benefit from introducing EEG in the routine workup?
Andreas, would you like to answer? Should I go ahead?
Yes. Again, we should, I think, probably think of likelihood ratio. So in a very elderly patient, where any test wouldn't likely change the likelihood ratio very much, we wouldn't gain much. But in a younger patient, where the prior likelihood ratio is lower, it might make a difference.
Okay, so maybe is to differentiate younger patients that have conditions, as you implied before, let's say like Lewy body dementia, where you expect a different pattern. I don't know if you have any data on patients with Lewy body dementia or frontotemporal dementia, where you expect the EEG patterns to be different compared to Alzheimer's disease.
We have not yet analyzed data from Lewy body patients. The presentation today was really preliminary because it did not include source analysis. Everything I showed was at the sensor level. It did not include the prognostic value of EEG, just the diagnostic accuracy, not the predictive accuracy. So there are a few things to be done. But what we have crystallized is the, we believe, correct approach of analyzing these data sets. We could argue, we could discuss that perhaps combining the passive EEG recording with some other stimulus. It could be a cognitive stimulus, or it could be a transcranial magnetic stimulus, would increase these values even higher. And this is certainly a fruitful path for research. So what we only presented today is the right methodology for treating the simple eyes closed, eyes open EEG.
So, which I find very fascinating with the, since EEG is widely available, is non-invasive, so it's an ideal test to be introduced in the clinical practice. So that's why I find it fascinating. So one last question, not to monopolize the discussion, is did you check for the drugs that these patients were under? So I suspect several drugs would make an effect on the EEG patterns.
Major confounder. We have not addressed this, no. And we should. But I think it's a little bit complicated to be precise. I mean, the types and doses of drugs that were taken at the time of the EEG recordings. I believe we can find this information and come back with this because it's a major confounder, as I said. Mm-hmm.
Yeah, and the effect on treatment, you know, after you introduce a treatment to a patient, if it changes. Okay.
Okay. And Dimitris?
Yes, thank you, Vasily. And I apologize for the noise that I have here. I'm sitting in a cafe, so there is not the best condition, and I had not so good connection. So I hope that you hear me. I just want to make a comment in addition to what Professor Kyrozis said. The way that he presented, I think it's a very standard also in the literature that they treat in this way, but this is the additive way as suggested by Professor Kyrozis, that you do a test, then you have the likelihood ratio, then you add another test, you change the likelihood ratio and so on. So these tests act somehow independently one from the other. I would say that we should seek an approach where we combine this, so in an interactive way, rather than use them as additive and independent to each other. So in order to increase the diagnostic accuracy, I think that we should definitely combine different tests from different perspectives and different approaches. So this would be a good idea, and use machine learning algorithms in order to do this, in order to reach maybe a biomarker finally.
Thank you, Dimitris. As I said, because probably you don't know him, Dimitris is a professor of mathematics. This is certainly the way to move ahead. And in fact, in our initial design, we had included all these other tests. But as I said, for time reasons, we did not have these data analyzed. We will certainly proceed and do that.
Yeah.
And I see that Kostas has commented that this is exactly the way to go ahead. So yes, we will. Nikos.
No, I just wanted to add myself, you know, the comment made by Kostas, but I think, I mean, I'm not sure unless I missed something that Dr. Kyrozis mentioning. I think that what Kostas has in mind is this, I guess, this cumulative increase of the area under the curve as you add additional tests. So, and we see it even with the biomarkers. That, you know, even the, you know, the blood biomarkers that have been recently developed, or the CSF, are not, you know, are not perfect. And the chances of getting the correct diagnosis increases depending on the background a priori probabilities where they are applied. I think we will be able to see some of that when we analyze the prospective data. There, the criterion would be slopes or changes or rates of cognitive decline. And then we may be able to see whether the EEG can add on something additional, can really increase the value of diagnosis compared to maybe clinical diagnosis, but also compared to biomarker data, which is available in this study.
Okay. Thank you so much, Nikos. I believe this is a discussion that can go on for quite some time because interesting points are being raised. But
yeah,
perhaps
I think Dr. Kyrozis also mentions, it's a very important issue, and I think this is where maybe the misunderstanding is that, whenever we add an additional diagnostic measure, it may or it may not be independent. And it's a great point that Dr. Kyrozis is making, that, it could be not independent, because there could be interactions with already existing previous measures. And it's an important thing to consider. And maybe with, with your skills and the mathematical background, you may help us with that.
We'll certainly address that in our next meeting on the issue. Any other points? Okay. If not, I would like to thank all of you for your time. I would like to thank Nikos and Andreas for the nice presentations, and all our colleagues, Dimitris, Yannis, and all our colleagues that have contributed to this work. And I wish you a nice evening.
Thank you.
Thank you.
Bye-bye.